yourself when you're not talking. And you can, if you want to get my attention, you can just raise your hand. When we go around and make the initial introductions, I'm gonna try to keep it to like 2 or 3 minutes.
Hi everyone.
I might like wave my hand if you want to wrap up.
Hi everyone who's coming in. Welcome to everyone. We'll just give a minute or two for folks to kind of trickle in, but we'll start in just a minute. Some introductions. I am Lee Pfeffer. I use they, them pronouns, and I am the Museum Operations Manager at the Historical Society. And tonight I'm going to be basically acting as your tech moderator, giving you a little bit of housekeeping, and then we will launch into our panel conversation, which will be led by our Executive Director, Terry Beswick. So if anybody hasn't been a part of a Zoom webinar before, pretty easy. We're basically going to be going through a whole bunch of different topics with our panelists, but we will leave time at the end for an interactive Q&A section. So what you can do is anytime you have a question throughout the entire evening, don't feel like you have to wait until the end to throw it out there. We're happy to take questions throughout. You can use the Q&A function, which is on the bottom in the middle of your bottom of your screen. So you should be able to type out a question there and send it to all of the panelists, and we'll be able to see it. And Terry will be going through and selecting questions as we go through our question and answer section. In the interest of time, we probably won't be doing a lot of unmuting folks to be able to talk from the audience, but we'll see how it goes. If you have something that you really need to say out loud and you can't express through text, please feel free to use the little raise hand function. If you click on that, it will show me as the host that you are wanting to talk. And so with that, I'm going to hand it over to Terry, our Executive Director, who will be moderating this panel.
Thank you, Lee, so much for helping us to get this set up. And thank you for everyone that's participating tonight. I know we're live streaming on YouTube as well, so there may be some folks on there, and we are recording tonight, and we'll be adding this to our website and to our archives for anybody who's interested in watching this into the future. And so again, my name is Terry Beswick, and so I'm happy to be here tonight. I'm really excited about having our wonderful panel together to talk about healthcare workers, and in particular how healthcare workers are impacted by the COVID crisis, and through the lens really of the AIDS epidemic, which our panelists have, or everyone on the panel has really deep experience working with people with HIV and AIDS around their clinical care, as well as overall management. But I think tonight I'm hoping that we can talk about how a pandemic, being in the midst and in the front line of a pandemic, impacts us personally, and how healthcare workers in particular are challenged, everything from having access to information to support through the healthcare system to emotionally challenges that we all experience, but I think in particular in a special way that healthcare workers do. And so I just want to give a little bit of background before we plunge into introductions. The Fighting Back series was something that we started a few years ago around the time of the inauguration of the current president. And it was a way to really try to bring people together to talk about topics that were really hot button issues or contemporary social issues through a historical context. And so we bring together people that were either personally experienced with that aspect of history or are historians together with policymakers or what have you, whatever the topic area is, to really explore an issue and and hopefully learn from the past and help it to inform our actions in the resistance, if you will, in the present time. And so, so we've covered so many topics in the last few weeks. We've gone into a weekly online format, and we've decided to focus specifically on COVID-19 and through the lens of AIDS. And so we've done, activism. We tried to get you to that one, Michelle, but I'm glad we got you tonight. We're all activists in one way or another, and particularly we wanted to look at direct action work on that night. And then we've also talked about artists, how artists function within pandemic environments. And I think next week we're doing sex and homeless issues a couple weeks after that. So everything is listed on our website, and I hope people check it out and engage with us on that. So I am gonna just go around and introduce everyone briefly and ask you each in turn to just talk about, for a couple minutes, just about your work in with respect to AIDS and or COVID-19 in terms of healthcare delivery and treatment, and then we're going to go around again, I guess, or just open it up to whoever wants to address a series of questions that I'm going to pose to you all. Feel free to interrupt each other. This is a pretty small group and pretty informal, and so I'm hoping that we'll have a good discussion and then get some questions rolling from the audience. But as people want to submit questions, we'll try to get around to them if we don't answer them in the course of our discussion. So with that, I want to just start with introducing Allison Moed, who doesn't remember meeting me, but I met her at the opening of the 5B documentary at the Castro Theater. Was that a year ago? So Allison was one of the original 12 nurses who in 1983 opened the first AIDS unit in the world, which was Ward 5B at San Francisco General, and she became a nurse manager there for 7 years. I'm going to come back to everyone, actually. I'm just going to run through real quickly. So Michelle Rowland, we've been brought together again by an epidemic. I met Michelle in the late 80s as part of we were both founding members of ACT UP San Francisco. I remember driving Michelle around one day in a car, and we were talking about, well, she was thinking about maybe going to med school. And, we were both interested in treatment issues around HIV and AIDS back then. And so she took that path, and Michelle got involved in clinical research, specialized in solid organ transplants and PEP through the HIV program at San Francisco General for 17 years. She directed the State Office of AIDS in California from 2007 and 2011, and became the country director for the CDC in Tanzania and Botswana for 7.5 years. And now she's in Jackson, California, where she's back to doing primary care. So I'm really excited to have Michelle as part of the panel. Lance Choma is the CEO of San Francisco Community Health Center, formerly API Wellness, which is an LGBTQ and people of color health organization that believes everyone deserves to be healthy and needs access to the highest quality healthcare. So Lance is actually along with me, has just been named a Grand Marshal of the San Francisco Pride's 50th anniversary parade this June, which will not be happening. But so it's just our luck to be Grand Marshal and get canceled. But these are small problems in the scheme of things, and we're going to go online with that. So welcome, Lance. Guy Vandenberg has worked as an activist, clinician, and director of programs, providing services to injection drug users, sex workers, incarcerated persons, and homeless people with HIV since 1985. He was also in the 5B documentary and was a Ward 5B nurse, and has and is currently not working in the field, is taking a leave from the UCSF's HIV clinic at San Francisco General Hospital. So with that, I'm with those introductions, and I'm sorry if I messed up anything. Let's just go around again, and if each of you could just fill in the blanks a little bit and maybe talk about, sometimes I think about how HIV and AIDS changed my life, or what my life might have been if I had not encountered HIV and AIDS. At one point in my life, I tried to sort of resurrect what I thought it would have been, which was doing playwriting. And then now I'm back into doing queer stuff. So anyway, but I'm always interested in that. It's kind of a thought experiment, but really just, how HIV and AIDS in particular changed your life. And in particular, how did it affect your work in terms of healthcare? Allison, can you get us started around that?
Okay. Okay, so
Say whatever you want.
how did it change my life? Well, I think that's one of the lessons. You can't have lived through those years without your life being profoundly changed, unless there's something wrong with you. It was an experience that that really, reached into my soul. On the most basic professional level, it certainly changed the way it affirmed what I knew of nursing, but not necessarily how nursing was being practiced at the beginning of the epidemic. That's that's a very practical, in a very practical sense. It affirmed for me that that's what I was, that I am a nurse, not that I do nursing, but that I nurse with my heart and soul. And in fact, that this was a work, this AIDS care became a work that, called to every aspect of that. And for me, I after that, you think, well, what really do you want to do with your life? Do you want to spend your time doing anything less than something that speaks to you on such a profound level and involves the best parts of yourself? Because that's what I think happened, that for those of us who were involved, it was the best parts of ourselves that brought us there, and it was the best parts of ourselves that kept us there forever, however long we were there. And not everyone, could be there for years and years, and no harm in that. It's just it was just a matter of experiencing one's own humanity and being able to share that with another. And so that was very important. How did that change my life? I mean, would I've had this realization? Would I've had this depth of experience? Would I have experienced such love and such pain without doing this work? I don't know. Maybe that's who I am, but I think it was a very unique time, and that those who lived with it, as I'm sure those who are finding now, who are living and working, nursing, or intimately involved with this pandemic, I'm sure they're finding the same thing. Now, am I like sort of floating away from the question?
Nope, you're perfect. You're perfect.
You asked.
Yeah.
You said you wanted personal, and I'm kind of like about the personal. So am I,
Yeah.
do you want to rein me back in a little bit? Or should I?
No.
Does someone else want to speak up? Because
yeah, we'll pass it along to Michelle. How about you?
Okay. Thanks. Thank you, Allison. You almost got me crying in the first like 30 seconds. So I was in my mid-20s, like probably many of us, and HIV was very personal. It was initially affected a friend. I started doing volunteer work through Shanti, and through my first Shanti client, I met Keith, who brought me to the AIDS Action Pledge, which eventually morphed into ACT UP. So very, very early on, my whole being was immersed in HIV, and I would not have become a physician if it wasn't because of HIV. I didn't like doctors, and I didn't like Western medicine, and Terry mentioned that we both kind of got really interested in the treatment activism, and it was through that I realized that I had a real interest and a gift in helping to translate complicated information and complicated feelings between affected folks and professional folks. So along the way, I believed that I would have the best chance at having the most influence if I had an MD, whether that was legitimate or not. I think I would have been a very happy social worker or a very happy nurse. But fortunately, I did end up liking doctoring. You know, it wasn't until 1 year ago that professionally I shifted away from HIV. And when I made the decision to come here to rural Jackson, California, one of the reddest counties in the state, and take on a full-time primary care practice, I felt that it was a reflection that I was finally starting to heal deep, deep inside, that my whole entire life did not have to be only about HIV. And so it is very ironic, because what COVID and these kinds of conversations brings up for me is that I have PTSD that is so just under the surface, and it is very, very easy to feel all of those feelings again. In my first semester of medical school, I had 6 friends and acquaintances die. Actually, it wasn't even a semester, it was a quarter. And I know we all have those stories. And I would just add one other piece right now in the introductory part. Because of HIV, I also had the opportunity to work globally. And Guy also will, I'm sure, have things to say about this. So I've spent a lot of time in Africa over my life for various reasons, but to spend 7.5 years, first in Tanzania and then in Botswana, deeply immersed in global health. You know, I was thinking about this on the way home today. This is it's not just AIDS, and it's not just COVID. I mean, and it's not just the history of TB and the history of polio. It is the current TB epidemic. It is the current malaria epidemic, where the only way that you can keep people from getting malaria is make sure they sleep under an insecticide treated net, and that you're doing residual indoor insecticide spraying. So there are massive parts of the world that are living with a pandemic of one sort or another, or multiple, all the time. And I think there are clearly lessons to learn there. And also it is incumbent upon us who are global citizens and activists to make sure that those folks do not get left behind to any extent that that's humanly possible. And it's hard to imagine when the care for people with COVID requires ventilators. So back to you, Terry.
Okay. Yeah, wow. Thank you, Michelle. I'm gonna just jump right over to Lance.
Thank you, Terry, and such an honor to be part of this panel with such amazing heroes and sheroes here. You know, in terms of my story, I actually I'm a social worker by training, and so I entered in the mid '90s as I started in the LGBT youth kind of movement and work in Chicago, and I worked in the program there, and so it was all, you know, it's HIV prevention dollars that actually allowed this program to function, and because the focus, especially on young people of color, African American and Latino young people in Chicago, HIV was so critical. HIV education, prevention education. So we were doing testing and all of our groups, and everything that we did was all around getting information, helping young people to come out and helping them to build a really strong identity around their queerness. Because there were so many other factors that were actually telling them not to actually be strong and proud. So that was how I came into this work. I moved from Chicago to San Francisco in the late '90s to work at Asian and Pacific Islander Wellness Center, because what I did see in Chicago was that there wasn't a focus on especially API communities, the native communities around HIV. And I saw that API Wellness Center was doing just that work. And so I really wanted to be part of those efforts. And so I came to San Francisco, and for the past 20 years have been at the same organization doing so much of the similar work around HIV in not just API communities and native communities, but Black and brown communities here in San Francisco, and just following the epidemic in the Tenderloin, where the homeless issue is so front and center. And so all of our programs in many ways now revolve around homelessness and marginally housed individuals living with HIV. And so I've just continued along that path. It's just, it feels, to be grounded in San Francisco, I feel like has been such a privilege and an honor to do this work here, because of everything that all of you, my other panelists, have been involved in. We, as an organization, we became a federally qualified health center a few years ago, and that was what many HIV and LGBT organizations across the country, that was a path of sustainability. I think I'm on the board of the National Minority AIDS Council, NMAC, and we really wanted communities of color, organizations that were minority led, to sustain themselves, and that was one path of sustainability. And for us, that was a huge transformation, and about 5 years ago, and now we are a full medical, dental, and behavioral healthcare center. And so now with COVID-19 upon us, we just kind of dove right in, and it's been this incredible journey of 5 weeks or whatever, 5 or 6 weeks that we've been in this fight around how do we protect and keep all of our folks in San Francisco safe and well and tested and housed. Of course, lessons learned, the parallels are pretty incredible when we think about who the virus is impacting, how we're kind of operating, like Terry, you were saying, with very little information or data that we're just seeing everyday changes, or we're just learning about what's going on day to day, and we have to modify our practice, our service every day, every minute, and so it's exhausting.
Let's come back to those questions.
Okay, sorry.
There's a lot to work with there for sure. No, it's fine. Guy, yeah, I'm really excited to have you on the panel as well, and talk to us a little bit about your experience, maybe how HIV and AIDS was life-changing for you is obvious. What I know of your work, but if you could talk about that for a moment.
Yeah, thank you for having me. It's good to see everybody. I'm honored to be part of this group of folks, kindred spirits. My path into HIV is not what people would assume, because I am a gay man, but I became involved mostly through losing friends to injection drug use. I was a runaway, lived in Amsterdam. There was a lot of injection drug use going on, and a lot of street-based sex work, and there was a heroin overdose epidemic kind of going on at that time. And so I dealt with loss. This was pre-AIDS. I didn't know what to do. I was lost, and eventually was helped by social workers and decided to become a social worker and an organic farmer. And that's not a combination that lends itself easily to employment anywhere, but I found a place in Pennsylvania that combined those things. And then again in Philadelphia and New York City, where friends and acquaintances lived, when AIDS hit, it hit the gay community for sure, but also very much injection drug users. And the concept of needle exchange, which I had gotten to know in Amsterdam, and methadone clinics did not really exist very much yet, and it was a struggle. I became angry and got involved with ACT UP on the East Coast, and there weren't really very good services for injection drug users and sex workers and other folks, dying of AIDS. Most of them were dying, and testing just became available. I had a friend who worked at General at the time, a Dutch physician, and he said, "We come and look in San Francisco, and we have the San Francisco model." I never left. I still feel like I'm still learning a lot. I get impatient with San Francisco at times, but like in the 80s and 90s, I feel like, and even now, with universal HIV testing, universal treatment, with PrEP, we are often on the forefront, and we have huge health disparities, and we have a lot of knowledge. As many people say these days, this is not our first rodeo, and I think there are parallels. I'm sure we'll talk about those more. But I'm still proud of a lot of the stuff that we do in San Francisco and of my friends and colleagues here.
Great. Thanks, Guy. Thanks, everyone, for giving us those little windows into where or how we view our past work from this standpoint. And I have so many questions and so many areas that we could explore that were raised here. I'm particularly conscious, though, each of you kind of touched on this in one way or another, but in terms of disparities of access to healthcare, whether it's here locally and between different neighborhoods or economic or racial groups, or across the world. So I'm really interested in talking about that with respect to AIDS, especially in the early days, and maybe I guess so. Also, I'm interested in particular with you, Allison, because I think you were involved in clinical care from the very beginning with HIV and AIDS, and so and I kind of think about now. I mean, the way that time works with COVID is very different from AIDS, of course, but I mean, we're as Lance said, 5 weeks into this, at least locally, but with AIDS, that would be 5 years, it seems like. And so, but when we go back to the early 80s at San Francisco General, it would be sort of equivalent to now, I think, with COVID, thinking about what we knew about clinical management and clinical care and how people presented and how we responded to all of the different opportunistic infections and so on at that point. But can you talk to us just a little bit about that experience, that just lack of understanding of what we were dealing with in the beginning, and how, and then we'll go back to talking about the disparities issue. Oh, I'm sorry, you're on mute, Allison.
Okay, no, I'm not on mute. I can talk to you about it in a few ways, because I came out from, I'm a New Yorker. I came to New York from New York in 1979 to San Francisco, and I was going to school. I was a registered nurse, but I was getting a bachelor's degree, and so my first, I had been used to working with injection drug abusers and alcoholics in New York, but my first jobs here in San Francisco were per diem work. We're going from hospital to hospital, so I could work part-time and devote myself basically to my studies. I was getting this bachelor's degree, and so I went to San Francisco General, and I was actually one of the first per diem nurses there. And that's where I started to see people with this young man. They were the people who I saw with this disease in the hospital then as a per diem nurse. There was no AIDS unit. There were just these young men who were housed in the isolation rooms in the back of the unit, And so nurses didn't really know. And you know, I was kind of a floater. I was not really attached to anything. So I would be assigned these patients because no one knew me and no one wanted to take care of them. So they wanted to give them to this extra person. So, and that was where I first realized how homophobic nurses can be, for one thing, because of remarks that they made, and also how I got a sense that they were scared, but no one was really telling me why, you know, and later as I look back and now as I look back, I could see that was really, that was a terrible thing, that no one was really talking to people about these patients, about their fears and concerns and their prejudices, about their apprehension that maybe they would get this disease that they didn't really know, and maybe they would die. You know, these are really important issues, but they weren't being addressed, and so people did. Not everyone is an activist, and not everyone has the sense of themselves in it, and people didn't necessarily speak up. What they did was they gave these patients to people like me, who knew even less, except I wasn't homophobic, and I wasn't unduly afraid. I mean, I was afraid as the next person, but I was going to do my work. I was a nurse, and my heart went out to these people. So that was one thing where we had settings throughout the world where there were people sick, as a sick, stigmatized population, whether it was young men, young gay men, or whether it was even injection drug users as they were coming in. Is a stigmatized population, and most people who didn't know how to take care of them, who, you know, and there was, and they didn't necessarily know how to get along in this hostile environment. So that was one thing. And then we started the unit. You are welcome to keep me on track if I digress from your central question. Okay, so then we started this unit, and it was very different. So we had a commitment. I was so fortunate, and I wish Cliff Morrison was here, and because he was the one who started the unit, and you know, he is our heart. I mean, he took this on, and he created this. He began the creation of a model that was then, and the model then was one that was very cooperatively developed. But Cliff, by the way, right now is recovering from COVID-19. So we can all send him our very best wishes from the bottom of our hearts.
There were a number of active nurses and physicians, you know, clinicians who are working with COVID-19 that we tried to get onto the panel, actually, and everyone was like, they couldn't commit. They're either working or, you know, just, but I'm really sorry to hear that, Cliff. And he is in recovery, though?
He is recovering. Yes,
Okay.
he's home. I mean, he has been home, but he is very sick. He is recovering.
Maybe for a future panel, but I'm wondering if anybody else has any thoughts about, you know, just the comparisons between and we could talk all night about the differences and similarities between different epidemics, and you know, and I think that's kind of like a slippery slope. But when we look at a specific narrow area, and some of this is sort of like emotional or subjective responses that you might think about, but some of it is just the challenge of getting the information, the challenge of getting the proper equipment, and the challenges of collaborating with other providers to care for somebody when you don't necessarily know what the best course of treatment is, or what's going on. Does anybody else have any thoughts about that? I mean, I do want to mention, you know, we hear lots of stories about limited access to proper equipment, you know, protective equipment, as well as testing and so on going on right now. But thinking back to AIDS, how did people deal with that? Michelle,
All right. So, I was thinking about back in the early days when we didn't have any effective treatments for the underlying disease. I think what we did is we fought like crazy in the clinical setting to treat all of the complications. And we treated and treated and treated and treated until we knew that the time had come when there was just nothing more that we could do. And then we transitioned to palliation. And so to be able to be a healthcare provider in that setting, you had to be comfortable with both. And you had to be comfortable knowing that it was partly your responsibility to recognize when that transition needed to happen, because you had to help the patient along, you had to help their loved ones along, you had to help the rest of your team along. And so I see COVID in a very, very similar way. What's obviously different, and other people have mentioned this, is the speed of things. And, so I have not yet taken care of a patient with COVID that I know of, at least not for their COVID. I am working with, seeing patients every day by video and in person. And I can tell you that I'm running downstairs to the triage to try to advocate to get my congestive heart failure patient up to the clinic, because I know that their symptoms are much more likely their congestive heart failure than COVID. But anyway, that's a small digression. But when I'm learning as much as I can clinically, because I am signed up and have emergency hospital credentials to go anywhere within my health system where the need might arise if that happens. And so it looks to me very similar that first off, you want to try to keep people at home. And there's two reasons for that. One is to contain infection, but also because being at home is a much better place for people to heal. And then when people are sick enough to come into the hospital, it looks to me like what the providers are doing are fighting like hell. Like we fought like hell against PCP or Toxo or whatever it was, or CMV retinitis or whatever. And then having to recognize that delicate moment when that fight is over. Like I said, it looks so fast and so intense, and like what the healthcare providers are experiencing in the places that are really overwhelmed, like in New York, just like the magnitude is just unimaginable. But in a place like California, where it does seem like we've been able to flatten the curve, I'm sure that everybody is also experiencing all of the trauma of the loss, but at a hopefully more manageable pace. And I'll just say, as I was leaving the clinic today, there was a woman who was standing on the grass outside of the hospital building, because my clinic is associated with the outpatient building. And I was walking over there and I was like, what is this middle-aged woman doing standing in the middle of this grass, kind of looking up at the building? And then I saw there was an old man in his hospital gown at the window on the second story, and she was with her phone. And that was how she was being able to connect with her father or whoever that was.
Wow. Yeah. I'm thinking a lot about, I have a lot of stories coming up, and some of the people that we knew and where those decisions were made about, clinical management of an opportunistic infection, and the point where you just realize you're going into palliative. And I'm having a lot of echoes going on right now. I mean, when you said, that there's a very fine line around PTSD for you, I'm definitely feeling like that, and I feel fortunate that I have a safe place and a work environment, a supportive work environment where I can sort of like roll with it, as time goes by. And I'm not working in frontline service either. And I'm doing a little bit of advocacy work to help maintain my sanity. But today, actually, and I'm getting together occasionally with a group of AIDS treatment activists, and we meet once a week, and we're starting a little Facebook group where we just talk about COVID, and none of us know anything, and everybody's doing a little research, and they're all lay people, But today I ducked into a kind of a ground round from UCSF. a Zoom meeting where they just had several clinicians just talking about acute management of COVID-19. And I was like, oh my God, I don't know any of the terminology. It just kind of reminds me of all that, you know, in the beginning when we were just trying to figure out, you know, what is cryptosporidium and all that stuff. It's really kind of overwhelmingly confusing, but there's a sense of urgency of trying to figure it out on the fly, how to respond. Guy, did you have any thoughts on this? Sort of how to treat on the fly?
Yeah, I mean that is fascinating, and again there are many differences and there are many parallels with the early AIDS epidemic days. So yeah, you use what you have, and sometimes that isn't very much, and then you follow the evidence. So it is a juggling. It's a ongoing juggling job, you know, of things, you know, that will work, whether they be palliative or treating, actually treating something, a complication or an underlying condition. So you don't know, but there are certain things that always work, you know. When somebody is short of breath, they use oxygen until proven otherwise, and compassion, and not just for the person who is sick, but also for their loved ones and what they're going through, which is a challenge now, again, in a different way, because people are physically separated. And as care providers, you advocate for your patient to have the best possible care, but also, you know, to advocate for them to have access to each other in as much as possible. And especially you advocate for folks who slip through the cracks. And we'll talk more about disparities, I'm sure, but the issue of PTSD, or maybe pre-traumatic stress disorder, currently is affecting me. I think in the previous epidemic, I was so busy that I didn't really have time, and I'm just starting to sort of think, partly because of participating in 5B, the documentary, to process some of that old stuff. And now actually doing some work with congregate living facilities and shelters and undocumented folks here in the Mission District of San Francisco. And many of them are not getting access, and bad decisions were made early on, and they were revised. I mean, the whole idea of making this mega shelter at Moscone Center was so ill-advised, and so you have to stay evidence-based rather than eminence-based. To, you know, like Dr. Peter Duesberg was a Nobel Prize winner or nominate, I forget, and people believed him when he said that HIV didn't cause AIDS, and we have to be vigilant today. And it's, you know, the treatments that the president advises are not evidence-based.
Yeah, thank you for that. And I think that really like brings us into talking about, you know, actually on the grand rounds that I was watching today, one of the physicians was talking about dealing with social media rumors around treatments, and you know, about whether it was a you know, I don't even know the terminology, what kind of a pneumonia it was that they were treating. And Michelle probably would know a little bit more about that. But you know, there's just a lot of confusion, and whether they're the patient or their family members are coming and saying, oh, I want to. And to be honest, I reached out to my doctor several weeks ago because I'm in a few categories of high risk myself, and I said, hey, what's this hydrochloroquine stuff? You know, should I get some while there's still some around? The prophylaxis, you know? And he said, no. And you know, now I've come to realize, you know, that there's no good research, you know, and it's all just a bunch of small observational studies, and there's conflicting data, and it's super scary. And I'm glad you brought it up. that the president would be talking at all. But specifically about this, I mean, but almost on a scarier level is like, I think we're really like trying to convey the message. I mean, I think as policymakers or part of the policymaker community or advocacy community, that people pay attention to the public health guidelines. But the problem is that I'm seeing sometimes the experts, the public health guidelines are questionable, or they change over time as new data becomes available. Masks is a good example, I think, around that. And that we're not trusted to be able to process the nuance, and so we're just told something that sort of will mollify us, I suppose. But I mean, I have my own suspicions and concerns around that. But I guess, yeah, it just brings up, and maybe we can come back to that, just how to deal with all the conflicting kind of information that comes in. But I wanted to ask Lance, are you experiencing in your clinic and, with the clinicians that you work with, the providers that you were supervising, their shortage of materials, whether they're testing materials or PPE, is that it? Yeah.
Yeah, all of the above. I think that's where this is our response now, as wonderful as we're seeing the curve flatten, in San Francisco, we're doing it while we have so little access to testing kits, to PPE, to any of that. It's remarkable to me, I've been having to actually work my connections in China because that was the only way I could get donations of just surgical masks. And so that's how we kept our doors open for a bit, especially when the orders, have been changing, but that, we all have to be masked as well as anyone who comes into my facility. For the first few weeks, we didn't even have a testing kit. We couldn't even get it from Quest. And so we had to test somebody, my chief medical officer had to test one of our patients in the SROs. And I had to call up another clinic, a partner clinic, and we ran over there the next morning so I could get a kit so that she could go and test our patient. And it was absurd to me, just the place we are in. And even now, we're still trying to figure out how to get surgical masks, how to get N95s. The city now still doesn't have enough small N95s, and most of my staff, and I think many, need the small. We have the larger ones, and so they're not going to work, if they're not fitted properly. And all of that to say, I just feel like the bottom line is that as good as we're doing, I feel like because we haven't gotten it right yet, we don't have all of the supplies we need. We can't test enough. That's where we just know from HIV is that communities of color, the poorest communities are going to suffer the most. And that we start to see it, that, Guy mentioned it in the mission, we're seeing that we need to do this more massive testing in the mission. We're seeing the Bayview, we see that, disparate, the case rates are higher in the mission and the Bayview out of anywhere. And it shouldn't surprise us. And it's still angering to me that we still have to deal with that because we don't have enough. We just can't do it all because we're not even equipped right now to do everything. We just started, I can go on and on, but even for our healthcare workers, for a couple of weeks, we needed to get tested because some of our folks were symptomatic, and because the tests were taking so long, the results, some of them took 8 to 10 days, and so I had healthcare workers out, even though they were getting better, but they had to wait for their result. And then not knowing was just this trauma that was kind of going through our system at our clinic. It was just crazy. So yeah, so all of the above, we still are in this place where we're still trying to figure out how to get the supplies we need.
Yeah, it's still at a crisis level, I think, in so many different ways. Michelle.
Okay, I just want to mention another one of the parallels between HIV and COVID-19. So I think we all come home, those of us who are dealing with clients and, still kind of going out and interacting with people. instead of doing the shelter in place that everybody else gets to do. We come home every day afraid of what we might be bringing with us, either us having gotten infected or on our clothes or whatever. The reason my hair is wet is because I come home, there's a place where I put all my crap, and I walk straight over to the washing machine. My clothes go in the washing machine, and I go and I wash. And it reminds me, I never had to live personally with HIV and the fear of transmitting HIV to the person that I loved or the person that I was having sex with. But I have a huge amount of empathy for everybody who has had to do that, and a huge amount of joy around the U=U data and the movement that has arisen from that. But I think that people who have lived with HIV for all of these years before we had those great data over these last couple of years know so intimately the fear of infecting people that we love. And this is a very real fear for everyone who's, whether you're a grocery worker or a healthcare worker or a taxi driver or anybody who's out there interacting with people right now.
Yeah. And I'm thinking about, like, when I got involved in AIDS activism, I was just finished my undergraduate studies in theater, and I was a white privileged suburban kid, and just kind of like learning about my sexuality and everything else. And I didn't know anything about things like prostitutes' rights, or prisoners' issues, or IVDU issues, or really anything about disparities in healthcare or anything like that. But through my work in ACT UP, which was really a coalition of different interest groups or different people interested in particular issues, I certainly became informed and radicalized, and that continued throughout my career. But I think the reason is because HIV and AIDS really uncovered the disparities that were already there in the socioeconomic structures, and certainly access to healthcare. And I think we're certainly seeing the same with COVID. So I'm wondering, like, what was it about? What could we have done? I mean, we're dealing with structural issues that really are influencing whether somebody goes in for care, receives care, the quality of care that they receive, what influences whether they live or die. When you're on the front line, I mean, you're just taking it as it comes, and you're triaging, and how can people, like, address these issues, in real time? Because it just feels so it feels frustrating on a policy level, but and certainly we can advocate for changes, but it feels so structural, and it's really like exposing. I've been particularly concerned around homeless people in San Francisco, who, I mean, people that are not even in the shelters, that just are shut out of the shelters and are living on the streets. There's no sanitation facilities provided to people at all. They're just sleeping on the sidewalk or in a tent. And forget about, like, if they become symptomatic or whether or not they're positive. I mean, so is there a question in there somewhere? I don't know. Can somebody help me out here, talk me off the ledge, because I'm feeling like really overwhelmed, and it's really resonating when I think about AIDS in those early years too, or even today. Allison, unmute, please. Allison, can you unmute?
I'm unmuting.
Thanks.
Yeah. I don't know if I can help you. I remember the helplessness that we felt in the very early days, when we were just starting to see the varied manifestations, the different opportunistic infections. They started, in the beginning, it wasn't so many of our patients were in homes so many of our patients appeared to do well, and then suddenly it was like a snowball, it just kept getting bigger and bigger. They came in faster and faster, and the diseases were travesties before, made them into travesties of who they were. And we started, and we had to deal with those opportunistic infections, as Michelle was saying. At the same time, they may become perhaps demented. And then the numbers were growing, so it was all kind of happening at once, and that was very, very overwhelming. And then there were deaths that were happening, and that was very overwhelming. And there were all the feelings. And I think that we did what people are doing now. We just put the pedal to the metal. We had patients to take care of, and we took care of them. And I think what happened then, and many of them were white men, and the wonderful thing about that is that they had voices, they had smarts, they had education, and they spoke out. And I think that was one way, on a very individual level, that healthcare experience became transformed. So a lot of what became the San Francisco model came because I think grew not only because of the care that was being given, but because of the voices that were being heard. And what they said, and they were speaking for the care of the individual, for the recognition of people and their rights. And now, and that's led to a lot of social change that we've alluded to here, and also some of the changes in healthcare, where patients are heard, where they can make their wishes known about their final days and how and when they want to die, to some extent. But I think it almost seems now the sheer numbers, the lethality of the and trajectory, the short trajectory of the disease, it does seem so overwhelming. And I can only imagine what it's like to be there on those front lines right now in those acute care settings. And I know that they're doing what we did, only they're doing it, magnified, where they are just doing what they do. They're taking care of people. As Guy said, they're making it up as they go along. And if they have to, they're keeping certain, principles of care that we apply to every patient, to every situation. We're doing that. It seems to me that it is so overwhelming, but maybe what we're going to learn now out of this is, as we learned the importance of the voice of the individual. Now, maybe we're going to learn about, I hope we're going to learn about that we have to honor, the collective in a different way. All the poor people that you're talking about, the people who are disenfranchised, they're in our faces now, as people were there then, they're in our faces. Not only that, a lot of people are losing, a lot of, the relatively affluent or middle class, now they're losing their jobs, they're losing their health insurance, they're experiencing that powerless grand scale. I mean, I'm as overwhelmed as you are, but my thought is we will come out of this. We know that we will come out of it, as we came out of those years, the 80s, the 90s. We will come out of it, and maybe we'll come out of it in shorter order, as everything now is so magnified. But may we learn. This is an incredible opportunity to learn too, and to see and to recognize the plight and the experience of those, not only in our own country, but like in Africa, as Guy and Michelle were saying, where we can't just continue to turn our backs anymore and pretend that these people are not part of us. It's here. It's like, in how cold will we be if we're able to do that? That's what I say to myself.
Thank you. Yeah, those are all really good thoughts. Lance and Guy in particular, I'm curious, just in terms of trying to reach those disenfranchised populations and making access to appropriate treatment more equitable. You know, do you have any thoughts on, you know, the comparisons between AIDS and COVID, or you know, what the situation presents to us in terms of potential change?
Yeah, I mean, I think I had to really think about, as we've had to respond, I've also had to think about how different HIV is than COVID-19. You know, that was a struggle for me. You know, like with HIV right now, you want to get everyone tested. You want everyone to know their status. We're trying to, you know, still make sure that that's happening. And it took me a moment to be like, oh, wait, we can't test everyone because we don't have the supplies, but actually we don't want to test everyone. That isn't the goal right now, because we can't treat everyone, and you know, and we need people to isolate, and they can clear the disease, or you know. And so it was such a radical change for me and my team to think, okay, how do we turn this around? Because folks were saying, I need to get tested, and we had to let folks know that, you know, actually that's not possible. But actually, why should they not get tested at that moment? So that was really hard for us, but we had to get around that. And then I think the second was just that we worked so hard around HIV to build community. And building community meant actually people coming together and taking care of each other and being in each other's physical presence. That was what we did, and we were so good at it. And you know, we have drop-in programs that I felt, you know, are life-saving for our HIV community in the Tenderloin. Every morning there's 50 folks in our drop-in for food and medication and direct care and love and that. And actually we can't do that. It was actually, we had to force them into their corners with this social of course it makes sense, but the words don't make sense. We want to isolate and distance and quarantine. You know, it was just like, oh my gosh, how do we incorporate those words back into our vernacular around COVID, when that was not what we were doing around HIV. So I think and we've had to shift all of our programs. So we have 2-minute touches with our folks curbside. You know, all of our HIV patients, they come, but they have a few minutes. But those few minutes that they have are life-saving. We see that every morning, where they can just have an interaction with our case manager or their behavioral health team. You know, they can see them for a moment has been game-changing. And what we've seen is how we've been reaching the folks who need to get their medication still for HIV. They still need that. They still need the connection. And so we're struggling, but we're figuring out how to maintain that in this moment.
Yeah, Guy, is COVID-19 going to give us Medicare for all?
Not unless we vote, but I have to think of what Tom Coates said. I think even before he was the director of the AIDS Research Institute. He said HIV points its finger at everything that is wrong in our society, or in any society. And COVID-19, the virus, points its finger at everything that's wrong on our planet today. You've seen the pictures of the sky over LA. You know, just beyond just the interhuman effects of our wrongdoings as societies, we see it in nature. We see the effects in nature. And do we learn, like Alison said, do we learn, or will we go back to a normal that we should not want to go back to? Today I was on my way back from the pharmacy, where I pick up my 90-day supply of meds in case I get sent to New York. I passed the building where I had made a home visit when I was still working actively at General. I'd made a home visit to a patient who was undocumented and sick and scared to come to the hospital, or too sick, or both, and found that he lived in an apartment that was smaller than mine with 18 other undocumented day laborers. That's within the region that is now going to get free testing, within that several block region there within my neighborhood. But are these guys going to trust the process enough to actually access that free testing, or are they going to hide from it? Are they going to trust that ICE is not going to come get them? And the other thing is, you know, that if they don't work, they don't eat. These are day laborers. They don't have access to other things. So a lot of the talk in these kinds of epidemics is about individual choices and individual behavior. But in many cases, it is really about all of our behavior. You know, how do we make sure that somebody in Africa or somebody who is a day laborer in the mission doesn't get sick? And of course we should do that anyway, because they're our brothers and sisters. But it's also going to affect all of us if we don't. And I think that this time is a little bit more clear than it was the last time around. It was a little bit easier during the early days of AIDS to say that happens to those people. And I think there are a few people who try to blame shift and call it the Chinese virus or whatever. But by and large, I think people are aware that this is all of us.
Yeah, we're actually doing one of these panels. I think next week the topic is going to be stigma around AIDS and stigma around COVID-19. So tune in. It should be an interesting discussion. Michelle, I'm thinking about, like, you know, a lot of the conversations I've been seeing online and in my little discussion groups right now among AIDS activists in particular are, you know, they're very focused on, you know, how we deal with the current situation, but people are also kind of like reflecting on just, you know, the immense collaboration that you're seeing, you know, where, you know, the medical journals are just publishing for anybody to have access, you know, that there's just an intense number of resources that are being put into this, and of course political attention so quickly. And everyone is really glad about that, I think, as a whole, but it also is just kind of makes you go, wow, you know, it took a long time to get attention to AIDS. And I think that there's a number of reasons for that. But do you kind of like have that sort of emotional response to it as well?
Yeah, so you guys remember Marty Bleckman. So Marty used to always say, if housewives got AIDS from sniffing Downy, we would have the response that we needed. And this is what COVID-19 is. It's housewives getting AIDS from sniffing Downy. So everybody feels vulnerable. And so, of course, everybody comes together. You know, I think that HIV is still a completely stigmatized disease, not just in the US, certainly in Africa. You see the stigma within countries, you see the stigma between countries, and it is still a completely othered disease. Even in generalized epidemics, people are horribly stigmatized, and it's the main reason that we still have HIV transmissions happening in those epidemics. Mm-hmm. And it's because people don't come out and say, I'm positive, I'm positive, I'm positive, I'm positive, I'm positive. And that's, you know, that is what it's going to take. It's part of why I think U=U has some real promise to actually helping us see our way towards an end to the HIV pandemic, which is by no way, in any way, over. I don't feel angry at all about what's happening now, but it can certainly make me very angry. I had an interview with a reporter from the J magazine, and, you know, she didn't really have any HIV history. And she was saying that, well, Reagan, of course, was nowhere near as bad as Trump. And I'm like, on AIDS, Reagan was worse than Trump. It's hard to imagine that you would ever say that anything was worse than Trump about anything. But yeah, so it's pretty easy to pick that scab off, although I'd say the emotional wounds are even shallower. But I guess I'm more, I'm not feeling very activist angry about anything right now. I'm feeling very much like Allison is saying, nose to the ground, get this thing done, take care of what we need to take care of. There's a ton of information. It does not make me anxious, Terry, that we don't know exactly what works. It doesn't make me anxious. The information is coming out as quickly as it possibly can, and we'll do the best that we can with the information that we have, and that I can live with that. I think what makes me more anxious is there's no actual clinical trial design going on. So there was a study published in the New England Journal of Medicine by a guy, the head of infectious diseases at UC Davis was the lead investigator. And it was a single arm study of a critical drug. And it was published in the New England Journal of Medicine. And I just go, I don't know what this means. I have no idea what this means. So, now this is a dilemma that really brings me back to the old days, because you remember a lot of what galvanized us was our horror around placebo-controlled trials. And, that patients needed to have access to drugs. And so, we got the parallel track thing going, and that ended up working, but it does take more time. And what we're seeing in COVID is just a lot of uncontrolled collections of data that are being analyzed very quickly and are clearly not being peer reviewed. They're being published without any kind of peer review. So I think we will make mistakes, and we can live with making mistakes, but I just wish we were seeing more in all those studies, like giant disclaimers. We're doing the best we can with the information that we have. This is crappy science. Beware.
Yeah, there is a dichotomy there that I'm constantly feeling like, we were fighting for the FDA to loosen up regulatory approvals, but also just approvals for access in a trial setting. And I think we learned during the course of AIDS, we learned a lot about controlled clinical trials. And about how just drugs into bodies is not always necessarily a good idea. But now we're kind of seeing like the opposite of that, and the FDA has like approved all these diagnostic tests in all these different labs without any kind of review process. It's apparent to me, at least, and so on, and so. I somehow I feel like, yeah, I agree. The activists that I talk to, they're not feeling like, to the extent that they have talked to people that are working in research, they get the sense that my job is just to get out of the way, because they're on it, they're working on it. But there are questions that come up like this. I would love to sit down with Fauci and say, what does the clinical trial network look like? What's the plan, around COVID, because this is kind of crazy. Let's see. So I'm wondering, is there anything that's coming up for people that you just want to talk about that you feel is not being addressed? I think we got like 20 minutes, and I want to see if there's any questions also. Oh, I have a question open. We're formally in the Q&A session. How do I find the question? There it is. Could you all talk a little bit about the similarities, differences you see in patient compliance during AIDS versus COVID? Adrienne asked. Patient compliance.
I'll just make one comment about adherence or compliance. One of the things that was been totally amazing to me about working in Africa, and I'm sure Guy could also speak to this, is there are whole populations of patients who actually take medicine, and they don't have to be cajoled to do that. And actually up here in this rural community where I'm taking care of the old people, 90-year-olds, 80-year-olds, they take their medicine. It's weird. So I don't know what to say about it. I mean, when I worked at San Francisco General, and I know that the data that we have around viral load suppression in supposedly developed Western countries is terrible. It's abysmal. So people oftentimes don't take antihypertensives. They don't take HIV meds. So it's a complicated, a very complicated set of issues. And I think there's a lot to learn about different cultures and different subsets of cultures that have an easier time and a harder time being adherent to the prescribed treatment. But I'm not really sure if that was what the questioner was getting at around compliance in the context of COVID. I'm not too sure.
Thank you for the question, Adrian. I think it was kind of like an open-ended question. Just how would you compare and contrast the adherence issues with COVID versus AIDS? If there's no other thoughts on that, I'm going to throw out a kind of a closing question.
There is adherence to the use of masks or face coverings, which seems pretty abysmal.
I just started thinking about when people are intubated and they have to put them under so that they don't, or it's hard to see like comparisons, but Lance, go ahead, unmute. Can you unmute Lance? Oh, there we go.
I was just going to say, what we're seeing actually, so in terms of some similarities, our street outreach teams that we have set up for HIV folks who are homeless or marginally housed, those teams we've expanded in the Tenderloin, because actually that's actually how folks need to get information and be informed about COVID. So we're actually using the same structures, and it is working. Like we do see, like our clients are so grateful that they're getting some information. They want to be compliant. Now we're teaching them about symptoms. So they're talking about, they know now, and we're asking if their friends are symptomatic, and then we're talking to them. And so there's actually been a beautiful way that I think, HIV has taught us how to do things differently. We can't just expect to have the clinic set up and people will come. We actually have to go to where folks are, and by using that model, I do think we're seeing that clients do want to take care. They want to get tested, but that's another issue. But when we're educating them, they get it. But now it's like you're saying, it's the mass. I'm concerned that we have this ordinance around face coverings, and the folks who are on the street, we're trying to get masks to them now. How can we get more cloth masks, so that we can distribute those on the street, because I'm scared that they're going to get whatever enforcement looks like around the face coverings. But I do think there is something, even the social distancing, what we see in the morning. We have like 30 to 40 folks. They know how to line up. They know this. We have the markings. There has been such appreciation and love and respect, and that's what my staff have been saying with all of our clients. They're really, really, really hanging in there, and that's what we've seen too. So I just wanted to say that.
Great. Thanks. I'm gonna throw a kind of a curveball question at everybody, and maybe just go around and give everyone a chance to say whatever you want in response. But this is a much bigger, we could do a seminar on this topic. Compare and contrast, healthcare workers dealing with COVID versus AIDS, and maybe we will come back and do this again in this forum or another. But I'm just thinking about, if you think back, given everything that you know now, if you could go back and talk to yourself when you were just dealing with HIV and AIDS in your practice or in your work in the 80s or 90s, if you could go back, given everything that you know now over the intervening decades, what advice would you give to yourself? And how, and I'm just thinking about for the younger people that are treating people with COVID now, and how that might pertain or help them. Guy, you unmute?
Oh, thanks. Yeah, that is a fascinating question, and For me, it's an emotional question primarily. Actually, in the early days, I was young. I was a young, newly minted nurse, performer, social worker, and I dealt by staying busy. That's how I coped, and by drawing energy from my anger and from love for patients and my loved ones. And if I could go back now, I would say that, do that. But your fear that allowing yourself to feel sadness and loss and grief, that if you allow those feelings, that they will overwhelm you and paralyze you, that they won't. Allow yourself to feel some of those feelings as well, and talk to other people, and extend the kindness that you extend to patients to your colleagues and friends, and don't be short with them, because they're going through a lot of shit as well. And then last of all, be kind to yourself. Be kinder to yourself.
It's beautiful. Thank you. Anyone else want to chime in? Michelle.
So I think I've said some of this in different ways, and some of it's a little bit similar to what Guy's saying. But one thing I would say to myself is, this shit hurts, and this hurt never goes away. So know you're going to be living with it, and figure out all the ways that you can take care of yourself. Because it's really painful. And I cannot imagine what the frontline healthcare workers are going to be going through as they start to come through this initial wave and get a little bit of a reprieve. And we have no idea, how long and how many waves, and it's going to hurt. It's going to hurt so bad. So that's number one. And number two is to not take for granted that the experience that we're having in our little piece of the world is the same experience that all the other little pieces of the world are having. And to really not take for granted the absolute abundance of everything that we have, even among the most marginalized here. Just keep our eyes open to the rest of the world.
Thank you, Michelle. Allison. One more try there to unmute.
Yeah,
Great,
I want to say to Guy and Michelle, yes, that's so beautifully spoken, and just what I would say. But I would also say, be so proud of yourself. In addition to that love, be so proud of what you've undertaken, and that and how you're undertaking it. The grace, the kindness that you're sharing, that along with the pain that comes back to you a thousandfold. Yes, I would say your life will be transformed. To take us back to the very beginning of this discussion, your life is going to be transformed in ways that you never ever could imagine. So cherish yourself and cherish your life as you are cherishing these strangers. As you're opening your arms to them, open your arms to yourself and honor yourself for what you're doing, what you're undertaking. I think it's godly work.
Beautiful. Thank you, Allison. Vance.
Well, ditto to everything that Allison and Michelle and Guy have said so beautifully, in terms of how how do we take care of each other and ourselves and our communities. The one thing I was reflecting on is just that for HIV, I always felt like if we had done better by Black communities and trans communities, we would be in a different place right now. I always think that. When PrEP came on the scene, that was the first thing I thought about, was like, actually, how do we do better by our Black and brown and trans communities, so that, you know, that could truly be a game changer, versus these communities always being the last, you know. And so that's what I'm sitting with now, is just how do I make sure that that's the big lesson for me, and making sure that's front and center in how we address this COVID-19 epidemic here and everywhere. So that's where I'm at.
Great. Yeah, thanks. You know, what I'm just kind of left with is this platitude, I guess, you know, that, I mean, I feel like, you know, this is, we're in a series of battles. It's a long war. And, you know, we're in some ways, we're all participants in it, you know, and we all have to bring what we can to help to bring some resolution to this, and, you know, to protect as many people as we can. I'm just really grateful for everyone to come together and share some thoughts and wisdom and experience with everyone here. As I said, we're going to be posting this on our website. It's also on our YouTube channel for people to check it out if you want to share it with people. And I just want to make a pitch also for anybody that's watching, whether it's on the recording or live. You know, this is a free event. We're a small nonprofit organization, and I just have to make the appeal that if you want to support our continued work in our exhibitions and our public programming and our archives for the GLBT Historical Society, please consider becoming a member. We're making a donation in some way. And that is my public service announcement for tonight. Thank you all for participating very much. And if anybody has any follow-up questions that they want to submit, you can send them to me. I'll put out my email address. It's Terry, Terry, @glbthistory.org. We're also going to be posting a list of resources if anybody has questions. We're going to post the Department of Public Health COVID page. You can just Google it also to learn more about COVID and how to respond to it. And I also just want to make a pitch for Turnout. Turnout has a great resource page around volunteer opportunities related to COVID, as well as other resources or places to donate. And Lee's got them posted also in the chat panel there for us. So please check that out. I love you all, and I really appreciate you all coming together tonight. And Michelle, particularly, it's wonderful to see you. Thank you so much for joining us. And, all right, thank you guys, and hope to talk to you soon. Be safe, wash your hands. Bye.